name is Biondi, as mentioned, and I still practice in primary care and then do these three focused practices, as well as lead the nurse practitioner program at York University. Molly, do you want to just say a quick word as well?
Hi, everyone. It's really nice to be here. Thanks so much for having us. And yeah, we're just really excited to share about this project, which hopefully will get further funding and continue to grow.
And we've been fortunate to be able to work with the folks at Women's College as well. So I just want to acknowledge the collaboration both in Toronto and Ontario-wide. So I'm going to start by just situating ourselves in sort of what would be like the last 10 years of HIV prevention. So as many of you might know, HIV prevention was approved in Canada a little bit after the US, and I'm not actually sure that we've caught up at all. So the focus of HIV prevention has largely been on PrEP in Canada, which is that pre-exposure prophylaxis. So taking the medication before someone might have an exposure. Certainly, these modalities have grown, being in an on-demand format, thinking about HIV prevention more broadly, such as post-exposure prophylaxis, as well as post-exposure prophylaxis in pocket. I'm going to go into those in a little bit of detail, just for overview and sort of updates, if you will, that are pretty new this year. However, because the data is fairly old on post-exposure prophylaxis, when we cite efficacy, the efficacy actually seems lower than PrEP. This is really a downfall of many of the studies that were done at the time, especially among certain populations. Access has been really community driven, and so there have been some communities that have really benefited from HIV prevention and some that have not. In Ontario specifically, we're also severely impacted by a lack of reimbursement mechanisms, whereas you might be aware that in some provinces, HIV prevention is fully covered in provinces such as Manitoba and British Columbia, although there are maybe a few more hoops people need to jump through, which again might be suboptimal. At least in the context of oral HIV prevention, most of these clinical trials really focused on gay and bisexual men who have sex with men, discordant couples, and perhaps women who engaged in sex work more recently. But therefore, the data really is skewed towards certain communities, and there's less data for folks who use drugs as well as cis and trans women. In terms of benchmarks for efficacy, there I'm also going to speak to the fact that there's some reconsideration around how we might think about efficacy, because again, there's been some real disadvantages to certain communities in the way that the clinical trials have been created and designed. Non-specialists, well, in Ontario, we do see an uptake by primary care in terms of HIV prevention prescribing. I'm going to share some data that there still might not be adequate knowledge, especially among women. And I'm going to just do a few updates on new modalities that you might be aware of, but maybe more with a women's focus lens. So when I use the term women, and you saw the asterisks on the first slide, I'm going to be speaking about cis and trans women. Although just to acknowledge again, in many of these clinical trials and lots of the studies, there will be disproportionately more cis women represented. But you might be surprised to know that outside of Canada in the US, HIV prevention uptake among women is actually pretty good. Certainly not in Canada and the US. But in places like Sub-Saharan Africa, many of the users are women or identify as women or female. I think the jury is, decided that oral PrEP works just as well amongst women as it does in men, and we're not doing enough to get that awareness out. We still get lots of questions from healthcare providers around PrEP in pregnancy. Actually, PrEP is crucial in pregnancy in order to prevent HIV transmission. And many are calling for discussions around on-demand, looking at things like Descovy for women. And I'm going to speak a little bit about that in terms of efficacy. This slide is actually from the World Congress, which was in Montreal in the summer. And this was a really neat study from a group in the US that looked at OTC PrEP. So really following for the format for emergency contraception for women and looking at whether it's pre-exposure or post-exposure, but really in an over-the-counter format. The data is really strong that it was very feasible, desirable, acceptable, and we can certainly do it. So just thinking about it in that space. Another interesting update is from the new CDC guidelines, which is are from 2025, and they were specifically around post-exposure prophylaxis for non-occupational exposures. And I just wanted to zip through just a few of these things to highlight that there's not quite enough work being done on adolescents, and adolescents are largely being ignored. However, the guidelines really encompass adolescents. I also want to speak a little bit about the transition from PEP to PrEP, which is probably not done very comprehensively. So essentially, if someone is offered PEP in an emergency room, which is the main place it would be offered in Ontario, they should be offered an immediate referral or referral pathway or linkage to HIV PrEP if that's what they would like. I'm also going to just point you to point number C down there about PEP in Pocket. So PEP in Pocket was really coined, created, invented here in Toronto by Dr. Isaac Bogosh. And it's pretty fantastic that it's now both in the CDC guidelines as well as WHO and more widely available. Funny enough, we actually found a paper yesterday in our scoping review about PEP in Pocket, and it said PEP in Pocket is being used in Toronto, Canada, and London, England. But it was actually London, Ontario, in terms of where that data was coming from. And this paper was from a group in Sub-Saharan Africa that were looking to use PEP in Pocket for women. So one misconception that might still be out there is around time to maximum protection. So the sort of common knowledge or the dogma, if you will, is really that women would need to take daily PrEP for 21 days prior to being fully protected. And this dogma is really being challenged because the pharmacokinetic data was really based on mucosal concentrations. And now it's being thought that mucosal concentrations are actually probably not the gold standard to monitor protection. So we can maybe be a little less demanding, if you will, around this 21 days prior to counseling people that they would be protected. And in fact, it's probably more like 7 days, as it is for gay and bisexual men who have sex with men. I'm sure many of you have heard about injectable PrEP. And so cabotegravir is our injectable PrEP that's currently Health Canada approved and has been approved for several months already. This study was for sure groundbreaking, and it was very focused on women. And I think one really interesting follow-up to the study that showed that cabotegravir, which is injectable PrEP, was superior to oral PrEP among women, was a very nice modeling study that really looked at if the women who really needed PrEP were on cabotegravir in sub-Saharan Africa, the incidence would go down by 29% in the region over 20 years. And I've thought about this a lot in the context of Canada and what communities might really benefit from this. And I do think we should do a similar modeling study in Canada because we will see that the incidence will go down. And this will be massively helpful from a research perspective to try to get policymakers to cover this medication across the country. Currently, cabotegravir is covered in Ontario for folks who are on Ontario Drug Benefit. Now, on the heels of that Health Canada approval, there was another major approval globally, the approval of lenacapavir, which is also an injectable PrEP. It was approved by the FDA earlier this year. And in this trial, the intervention arm, or sorry, the control arm was actually discontinued because the intervention arm was so strong that it would have been disadvantageous to those who were in the control arm. So this will be a game changer. It's an every 6-month injectable prevention. A few things to think about is that injectable part, right? So this means that folks either need to be trained or need to access a healthcare provider or a pharmacist or whatever it's going to look like in Ontario. But also just to mention, there are multiple observational studies that are already going on in the US to sort of look at some of these things and look at models of care, including of Purpose 4 trial, which is going to be specifically focusing on people who use drugs. I also wanted to share some of our local research that we've been doing for the last few years. So this study was a survey-based cohort study that looked at basically the preferences, desires, access to HIV prophylaxis in Ontario. It was completed in 2023, 2024, so it's not too old. It was done in 15 community-based organizations, which included shelters, addiction treatment centers, women drop-ins, basically programs that had women. So we really felt like these were sort of the right places to do it, if you will. One of the biggest findings I think was really impactful was that we asked both about subjective risk factors around sex as well as around drug use. And then we looked at objective sort of risk. So did people think that they were at risk based on the types of activities that they were engaging in? And actually they did not. So there was a real disconnect between risk assessment that was personally and maybe objective, but even amongst those who really felt like they were at risk and could benefit from PrEP, there was extremely low offerings of PrEP. So interestingly, many women thought that they weren't eligible for PrEP, they wouldn't be able to afford it. They were concerned about side effects, and they were concerned about actually the frequency of appointments. And I think this is helpful to think about in the context of injectable PrEP, but also in the context of the type of care that we're facilitating and how we can make it more what we call low barrier. We've also recently presented a survey study that was amongst Canadian healthcare providers. And so in this context, we surveyed nurse practitioners, family physicians, and OB-GYNs. And this was really inspired by a very specific patient that I had who was declined HIV prevention by their obstetrical provider. Um, in total, there were 114 participants, and this was specifically focused on women. So the knowledge to prescribing was low. Most people felt like they could probably do it if somebody asked, but they were not universally offering it or speaking about it, and definitely not in a co-localized space such as cervical screening, STBBI care, or sexual health. At least half thought they would refer to the emergency room for PEP. And for those of you who are not familiar with this format, PEP in the emergency room is a fairly terrible experience. People will be in the emergency room for 12 hours, 24 hours. They need to get blood work, and they're almost never given the full prescription. So they're given 3 pills or 5 pills, and then it's really up to them to systems navigate how to get the rest, especially if they don't have coverage through the province. Providers certainly identified that they initiated more conversations with men than women, and that medical education really focused on HIV prevention from women could increase uptake. Um, so when we think about HIV care and treatment now, I'll just sort of flip gears a little bit. This is, I think, just a really relevant slide. It continues to be very relevant. And of course, there's new data out or coming out, but really to look at time to viral suppression amongst people who are HIV positive, and that it's really abysmal for women in terms of it being much longer than it is for men. So I'm going to chat a little bit about our current funded research. So we had an interest in starting a collaboration, which has been amongst many, many investigators, community providers, to really think about what are the facilitators and barriers in community to HIV prevention and treatment among women in Ontario. So this was our initial sort of foray into this work. This was based on community discussions. So we developed both a community advisory board, which is made up of community members, as well as a service provider advisory board, which was made up of particularly nurse practitioners. From that sort of initial engagement, we came up with what's called implementation science question, inequities in the access to HIV prevention and treatment for women in Ontario, and submitted a CIHR grant with 3 specific aims. The first aim was we wanted to co-create a sustainable framework for partnerships because this is community-based research and it is with community identified at the center. Second, we want to identify multi-level barriers, enablers to expanding trauma and violence-informed HIV prevention and care and treatment in Ontario. And then thirdly, to identify priority areas. And we're going to speak a little bit about who we worked with in terms of focus groups. But we were successful in this LOI. And so now I will pass it over to Molly to talk about what we did after that.
Thanks, Mia. Okay, and you're gonna do the slides. Perfect, thank you. Okay, so I'm gonna talk a bit about what we did, and I'll just briefly cover also some of the high-level findings to the project. First, in terms of, we spent a lot of time really thinking about how we wanted to compile our team structures, knowing that there was a lot of academic and professionalized interest in this project, but as Mia talked about, a lot of women don't see themselves at risk. And we also know that, so it's important to think about how we get this to community, how we get buy-in from community, and also how we get leadership from community to know how to formulate efforts that really center people who are excluded. And we also know that since people don't see themselves at risk, we needed to think about what are the ways that we can link this information back to community who face disproportionate risk. So really early on, we decided that community leadership would be really important. We decided that participation from the voices of people who are excluded and face the biggest health inequities would be at the center and leading the project. And given that we had a lot of academics, and often these kinds of research projects are really driven in academic spaces and ways, we wanted to be thoughtful about how we create a space to foster community dialogue and voice that balances with the academics at the table. So we decided we wanted to develop a governance structure, and to do that in a way that really brought in a diversity of input into the project. So we started with doing a bunch of brainstorming in different ways. We had sort of one-on-one phone calls, we had brainstorming meetings, we had a Google Doc where people put ideas in. We expanded our advisory in terms of both service providers, so nurses from a range of different areas, and also women from a range of different regions across Ontario, including both cis and trans women. We also looked at our leadership team, and we got input from all of these different groups into the governance structure. The governance structure really looked at how to develop a model of collaborative leadership so that we would be co-creating, as Mia said. This meant that meetings would be co-chaired. We would integrate activities that came from the community and strategies to make sure that we were having participation from folks who are really quiet in the room, and balancing out everyone's input. And we also created an evaluation sort of strategy for each meeting that we held. So we actually evaluated at how we did at meeting the governance tools or the governance structure through each meeting, both including service providers, the leadership team, and at the community advisory level. We used a range of different tools for engagement. We had activities and meetings. We had different ways to give input into focus group structures. And we really looked at how do we fundamentally weave in values of anti-Black racism, cultural inclusivity and thoughtfulness, tools to really encourage different styles of participation for people who are more outspoken and who are quieter. And how do we really sort of encourage collective engagement and different perspectives? So we really focused a lot on the health equity, and that was a really big part of the process. And we also really want to be effective at centering the voices of people who have experienced incarceration, who don't speak English, migrant sex workers, those who are in remote communities. All of these voices were really important to our early planning and to our team structures that we had to inform the work. Then for focus groups, we collaboratively planned them with input from all of those different groups. For women, we linked with the communities where we were going to be implementing to ensure we had trusted champions in the community that women would be comfortable to speak with and to engage with, and who could help organize the events. We did focus groups that focused on migrant trans sex workers, people who use drugs, cis and trans women who use drugs, women living with HIV, ACB women, women who had been incarcerated, and also women who newly moved to Canada, so newcomer folks. For nurses, we also were really conscious that we know that it's really important to see some connectivity in terms of nurses who are doing this work. And we know that there's a dominance of white nurses. So we really wanted to think about who are women going to be connecting with. So we reached out to the Black Nurses Association. We worked with some rural and remote nurses who work in a range of different communities. We reached out to Indigenous communities, and really worked to ensure we had a diversity of participation from nurses, which was a lot of work. That working group put a lot of effort into that. We also recruited from the Women in HIV/AIDS Initiative, which, for those of you who don't know, is a group of folks from across Ontario. So we've got workers in 16 different communities across Ontario, and they're housed at AIDS service organizations. So we did focus groups with executive directors from those organizations and managers, as well as with WHAI workers, the Women in HIV/AIDS workers. And finally, we also met with folks from the Ministry of Health to get their input and make sure that we were formulating ideas in ways that would work with ministry frameworks and understandings of things. So from there, we all participated in developing focus group question guides. We, especially for women, developed a range of different tools and we workshopped those. So we had arts-based tools, we used analogy, we workshopped some different facilitation tools to foster engagement. And we did some online focus groups, particularly with nurses and with women. They were mostly in person. I think they were all in person. And we put a lot of effort and thoughtfulness into who we were recruiting for those spaces. And particularly for women, having local leadership was really critical to that process. And the next slide gives a bit of an overview of who participated. This is a complex slide. The first column is sort of like which group it was. So you can see women with living experience, nurses, RNs, AIDS service organizations, WHAI workers, and the Ministry of Health. You can see the number of groups and the number of participants. So in total, we had 88 participants in all of these focus groups. And then the last column there, we realized sort of partway through that we hadn't created a tool to understand who we were talking to and to also see what the gaps were. So we actually worked together to sort of do a retrospective. So this is empirical data for sure, but to look at who did we engage just from our knowledge of the groups and who might have been missing. So you can see there in that last group sort of a breakdown of who participated. We wanted to make sure we weren't sort of just talking to white women. We wanted to make sure that there was Indigenous women and Black women, women who had been incarcerated, women who had migrated. So you can see the range of folks who participated there. And from there, we went into analyzing, and we had a lot of information to analyze. And so we used a approach called a rapid turnaround qualitative research method, which was new to lots of us. And we also really wanted everyone from the different groups that were informing this, from the leadership team to the community advisory to the service provider advisory, to be participating. So we worked together. Those of us who could, we came together for an in-person meeting. Those of us who couldn't attend the in-person meeting attended an online session after that. And we also had some one-on-one and engagement and some opportunity to read through things independently and give input. So you can see here the picture from our in-person meeting. The next slide shows sort of a little bit about the process. So on the left there, you can see our agenda. You can see Karen explaining our process. And on the picture that Karen is there with is the list. All those squares are the different focus groups, color-coded. And then the next one over, so beside Karen to the right is we would move the pieces of paper there once they were completed. So we each took time, we reviewed the transcripts from every focus group. We created summary documents for those and then moved them to that flip chart paper. And the last slide there is any quotes that really stuck out. So something that like really struck us or was really meaningful or impactful, we recorded as a quote to help continue to inform our process and to sort of define and sort of flesh out what we were hearing from community. Okay, and then in terms of results, I'll just really briefly go over. So the first one we looked at is women with living experience. And throughout this one, we really heard, so we talked to, again, trans women who did sex work, newcomers, women who use drugs, women living with HIV. There was a really great range of age groups involved. And throughout, we really heard that all of those folks that participated wanted to be involved. They wanted to be leaders and educators and collaborators in the process moving forward. And we're really eager to do that. And we're also very well positioned in terms of their relationality with other people in the community. And knowing that, especially for those who don't see themselves as being at risk, as Mia had talked about, that would be one of the best ways to bridge information sharing and engagement. We also heard that it's really important to pay women, of course, for their work. There was a lot of interest and excitement about doing training. And also one of the key pieces that we heard, of course, is like flexible access to care is really important, balanced with a one-stop shop. So people don't have to navigate and go to a whole bunch of different places to get their care, whether we're talking about access to prevention or to HIV treatment, that they can get that at one location. But also for some folks who wanted to access various spots, that it be flexible. We also heard a lot about the value of mobile services. And so really to think about like different things work in different communities and for different people. So the need to be really flexible in the approach and to be locally adaptable. And then finally, we really heard about the value of leadership pathways for women so that women would engage in helping to implement this project if we get funding, which hopefully we will, and that women wanted to stay involved in the leadership throughout and support the work throughout. In terms of AIDS service organizations, and what we heard is that AIDS service organizations really know the structures and could help us to embed it where it works in their community. Could help when there's significant staff turnover, which we know that there is an ongoing sort of turnaround of staff turnover. So linking strongly with AIDS service organizations helps to model some continuity of care and connection. We definitely heard a lot about population-specific approaches that work, different approaches that work for different groups and different folks. The importance of adapting locally. What works in one community isn't the same thing that will work in another. And really, one of the things that struck me the most is sort of this comment that that ASOs are in relationship building business. So they're really well connected in their community, and they're really good at leveraging those relationships to help do this work. In terms of WHAI coordinators, we really heard that WHAI coordinators are the connectivity in the work in terms of navigating through various stakeholders, through community organizations, the AIDS service organization, and also women in the community. And that they're really great at sort of fostering women-centered spaces and could be a really pivotal part to developing local train the trainer models and peer advisories to support the work as it moves forward and make sure that it's being developed in a way that works for their local community and for the women in the community. And maybe I'll pass it back to you, Mia, to talk about the results from nurses and the Ministry of Health.
Great. Thanks, Molly. That was fantastic. Yeah, and just to sort of center us on what we're doing. So with this part here that we're talking about with phase two, so really this phase one was to do the focus groups on what could or should models of care look like that are women-led, women-centered, particularly with nurse practitioners and registered nurses sort of leading the way, if you will, especially registered nurses who are working in extreme expanded scope of practice in places like Northern Ontario. And one of the reasons for this was for sure, as I mentioned, because nurse practitioners are an increasing group of prescribing HIV prevention in Ontario. They also may work in the kind of the right places, if you will, like dominantly work in community health centers, doing shelter-based clinical work, as well as the fact that there was something called the facilitated access list, which meant that only a physician could prescribe HIV treatment. Only a physician could be on the facilitated access list. And this was actually abolished in 2024. So some of the motivations around specifically nurse practitioners. We heard a lot of different things from different nurse practitioners and RNs that were working in different settings, but particularly looking at facilitators of HIV care. There's for sure a passion for this work, an interest in this work, and people identify that they have the ability to build long-term relationships with patients that foster trust and are essential for effective prevention and treatment. I should also say something that came up that's not on the slide, but comes up fairly regularly, is that in Ontario, we have something called the hepatitis C teams. So these are Ministry of Health funded hepatitis C teams that are largely RN and NP driven and work with a lot of these folks already. So that came up quite a bit around co-localizing care or shifting care to include HIV prevention and treatment. There were some challenges for sure, things like the need for infrastructure improvements, thinking about things like they were aware that a flexible option would be important, that a mobile option would be important, but how do we actually do that with the current resources? There was some discussion around limited certification pathways, and that also kind of transitioned into really like mentorship pathways since certification is not required. But also, maybe just to pull back into things that we might have heard at like ASO level, would be that in some communities, there's still a physician dominance for infectious diseases. And because HIV prevention and treatment might fall under infectious diseases, there was sort of a need for like permission seeking in a certain community rather than just people feeling confident they could go ahead and do it. Um, Also, just speaking about burnout, certainly in community health centers, clinician turnover is quite high. And so, how do you have continuity of care when there's clinician turnover every year or every couple of months? There was a real desire to have more mentorship. And I just want to give a shout out to Mona Luffy, who's here on the call, because she was one of the investigators. And, if we're funded, we really hope that Mona will play a key role in mentorship, which will be crucial in terms of both her positionality with HIV prevention treatment among women, but also just as a clinical leader. And mentorship doesn't have to be, necessarily like this with a webinar. I mean, nurse practitioners and I think clinicians generally in community are looking for quick access. So that can be honestly things like texting, emailing, really looking at quick answers, quick support in real time while the patient's sitting in front of them, or within 24 to 48 hours. There are some pathways like that in Ontario already, but they're clunky. Things like e-consult, and they take time, and they might not be as accessible. In our phase two, what we heard from nurses, so RNs, was that actually there's probably a link there between NPs supporting RNs towards medical directives and really embedding programs in things like community health centers that already have really fantastic, robust multidisciplinary teams that already often are a one-stop shop for lots of different communities. There's also an interest in normalizing HIV testing as a part of sexual health visits. For whatever reason, HIV testing is often left off a routine sexual health visit, and really integrating health promotion and awareness and, whether it's formats around posters or postcards, really looking at how to better support advertising or awareness of this as a modality, especially again in co-localized settings where you're already talking about women's health or sexual health. And really, they would like an investment in mentorship, leadership development, and really kind of that wanting a seat at the table piece. So, with our work with the Ministry of Health, we actually did not have a fulsome sort of focus group with the Ministry of Health. Some of the results from the different focus groups that Molly and I have spoken about, they were very broad, and we really wanted to bring things to the Ministry of Health in terms of priority setting. So, what were things that they shared the values on? What were things that they could provide clarification on? Are there future funding models that are available? And for sure, they echo the perspectives shared by all groups and this idea that there needs to be a specialized, women-centered, facilitated model for HIV prevention and treatment. They are painfully aware that many people are traveling for hours to get HIV treatment, painfully aware. So it's not that that's not on their radar. Over the next 5 years, they felt that implementation should really be phased. So focusing on communities that really are the most in need, and might have those strong partnerships already, and then continue on from there. Molly showed a slide there that had the different Post-it notes, and one of them actually said Sioux Lookout. And Sioux Lookout was a community that we were not able to access for various political reasons. And we've since been able to sort of engage in some way with Sioux Lookout. And so the Ministry of Health, again, is aware of these sorts of, whether it's called the turf war or just a low resource area where there's not the resources in place to support this type of care. Leveraging health units was thought as a really good idea in leveraging Public Health Ontario, and they actually offered to facilitate trainings with health units, which I think is really crucial, because although the health unit might not foresee themselves doing HIV prevention and treatment, certainly with their roles in routine STBBI testing and treatment, they could at least link people to this types of care. thinking about being involved from the outset. So the ministry actually, offered for very routine meetings every 3 months. They really want to be up to date on the project. How are things are going? How can they support it? And, I think we felt really supported in terms of collaboration there. So for our next phase, what we've done is we've basically taken all this data, somehow succinctly put it into a 10-page grant with 17 other documents that are 5 pages each, as we have to do for our national funding board, and really hashed out a 5-year proposal, which for the first year is very focused on additional focus groups and consultation. So we can't possibly do the consultation we needed to do in 6 months, which was our LOI timeframe. And so we really highlighted our first year to do more engagement, especially among communities we didn't reach. We've also very much focused on training and capacity plans for women, NPs, and RNs, WHAI coordinators that are embedded in ASOs, as well as academic trainees. We put forth a DEDI plan, which was largely community advisory board driven, as well as our training capacity plan was also largely community advisory board driven. So when we're thinking about co-designing models of care, again, we're talking about this concept of implementation science. So it's sort of like a clinical trial, not quite. And what we're doing is looking at different hybrid models of care, where co-design is the cornerstone, where we're looking at holistic, inclusive, and sustainable treatment. And things that came up as top priority were embedding into gender affirming care, Indigenous healing practices, having culturally competent providers, and having some sort of systemic reform around addressing stigma, racism, and what was termed as gatekeeping in our focus groups, which is really speaks back to some of that original data I shared around access and people not feeling like they were eligible for this type of HIV prevention care, largely because of what had been told to them by healthcare providers and other folks. We had a data management plan and then again a knowledge integration plan, which, thanks so much again to the Women's College team because this is definitely a part of our knowledge translation for this work. Molly, are you doing this one?
I can. Sure. So we actually heard a lot from community about what kinds of report back would be helpful. And the communities of women in particular who participated really wanted to hear, an update about next steps, where the project was at. And we wanted to do that as well because we want to keep people engaged in the project so we can leverage those relationships and women can be involved if we get the funding. And even if we don't, can be involved in implementing and strengthening this work. So we decided to do one of the things that actually the communities asked for is an infographic about next steps. And we've really decided to do 2 infographics, one really driven by sort of a more informal and community-led approach. So some of the folks who helped to implement the focus groups locally, the community champions are helping to develop and design that. In ways that work for their community, so they may adapt it based on the population that they had involved in their focus group, and we're all collaborating on that. And then we also plan to do a more formalized one that can be shared more broadly and can also be shared with the service providers, nurses who participated, that we'll all review and make sure it accounts for the things that were shared in the various different focus groups. We also shared about this project and some of the context at a Northern Regional meeting that was held back in August. We did a report back at the WHAI coordinator meeting that was in person in October. Today, of course, we're here. And there's also something for the OHTN in November. So we're in the process also of planning get-togethers in the communities where we did the focus groups. So we'll share the infographic at those, and we're really trying to support the folks who organize those to come back together, maybe share some food and talk about what came out of the project and what women locally shared. And then we've also submitted a few conference abstracts. We submitted to CROI, but sadly did not get accepted. And we're working on a few other conference abstracts to share, and also some manuscripts to share. Mia, I don't know if you want to share any more about those.
That's great. Yeah, it's in the works. We're not sure where they will land, but we're excited to see it get out there. So maybe in terms of next steps, so As I mentioned, we're really looking at this 0 to 18 month around additional engagement if we're to get this funding, which we really solely hope that we do, where we're really going to discuss the priorities. But I wanted to share with you the two types of models of care that sort of emerged. So again, kind of coming back to the results. So they're both community driven. There's no sort of hospital-based care that we're discussing here, but one we've called integrated women's HIV care. And this is like an in-clinic, in-community type format, with some of those pieces around flexible hours, some of those pieces around one-stop shop, but really more like an in-clinic type situation. And then the second is really an outreach, pharmacy-linked teleprep, PEP, PIP, antiretroviral therapy that would be outreach and virtual. And it's not to say that a community has to decide between these two things. There might be multiple options, there might be a mix and matching, but alongside these models of care, we'd be collecting clinical data, but also more importantly, the experiences of the women who are engaging with these models of care. And I think a big part of what Molly and I and the team have discussed is that women will be leading this care. And that's a big part of this grant to make sure that they have sustainable roles within this funding. So we're super happy to engage with anyone who might want to get involved in this next phase. Again, even without funding, we really feel committed to make sure that we get this work out there. So at least for the next 1 year and then hopefully for the next 5. But really engaging with WHAI coordinators and ASOs. And that's part of our feedback to go back to those folks as well to go back to the NPs and RNs who were involved in the work. So this was a very, very, very big team. Molly, maybe 30 people, maybe a little bit more. And I just want to really acknowledge the partners and the advisory committees, the clinicians, the service providers who have shaped this work. I can't say everyone's name because most people are still called hub member, but I do see Grace and Shanice, and if you're comfortable, feel free to come on camera. But just really want to thank you and acknowledge you for your leadership. Grace is a co-principal investigator on this work. Shanice was a massively, massively engaged community advisory board member, and we really hope to see to work closely. There I have just an example of what is sort of my clinic handout. That's a women's oriented HIV prevention. How do you engage in HIV prevention care? And then I also just want to acknowledge the many people who are trainees in this work because they've certainly gone above and beyond in their training program. And finally, I would like to thank Molly, who really has driven so much of this work. And Molly, it's just such a privilege to work with you. And I think we can take any questions.